discuss about the important practical aspects of the ophthalmology and what are the important theoretical questions that could come out of the practical aspects. So today we'll be discussing about the possible causes of this sudden painful loss of vision in a 34-year-old female patient, and we'll discuss the differential diagnosis, symptoms, signs, and management of the loss of vision. We'll also discuss about the gradual loss of vision causes and in detail about each cause. And we'll also discuss about the tonometry and its advantages and disadvantages. We'll study about the B scan, colored halos, Snellen's chart, and we'll also study about the methods for recording of IOP. Okay. So before starting today's lecture, let me just give you a brief introduction of what is Auricle. So here at Auricle, we have recorded classes, we have live classes, we have practical sessions, rapid exam modules, and hard copy book set. So in the recorded classes, we have, so the recorded classes, it offers you the freedom to choose from the multiple educators and to watch the videos at your time. It provides you flexible learning and it covers all the topics that is important specifically for your MBBS Prof exams in India and also your FMG exams. And it also covers the topics related to your entrance exams, okay, NEET PG entrance exams. So these also is very convenient for you to revise at the last moment of your time or just before your exams. Other than that, we have live classes. So like this one. So in the live classes, the past 10 years, previous year questions. It includes all the previous 10 years questions and the most anticipated questions that could come in your exam this year. And it provides you the in-depth coverage of all the important topics and all the important questions. And it also helps you to participate in the live classes, like participate in the live doubt clearance. If there's an MCQ quiz, the Viva questions, if the tutor asks you. So for your last moment revision module, we have the express exam modules. So this express exam module gives you the complete syllabus in under 20 hours, which is very comprehensive and efficient coverage of your complete syllabus. And all the important parts or all the important questions are covered in this express exam modules. And it will focus mainly on your answer writing skills and the important questions, okay? So that you know how to draw your diagrams, flowcharts, or effective answer writing skills. We also have one-to-one doubt clearing session where the student can ask their doubts to the respective educators. And this is a very student-centric approach, and it helps us to create a safe learning environment amongst our students and the educators. We have hard copy note set, and we have made these notes in a very crisp and concise manner so that it becomes easier for you to read and to remember those notes or to remember those topics. And it also has beautiful colorful diagrams, which is essential because you need to draw diagrams in your answers. And these notes helps you to draw answers in a very schematic way. Okay, and these notes also contains previous questions and most important questions. Okay. We also have question banks for the practice sessions, and these question banks are very important because you need to know or you need to judge your knowledge or to practice your concepts, right? So these question bank covers MCQs for your prof exams, for your PG exams, and also for your FMG exams. Okay, lastly, we have the practical sessions. Okay, these practical sessions are very important because practicals also are very important for your main university prof exams. And these practical sessions provides you hands-on experience and in-depth covering understanding of your MBBS practicals. And these practical sessions also helps you to answer your Viva questions or how to give your Viva answers. Okay, and because in practical exams, you need confidence and skill. Okay, other than the theory part, you need the confidence and skill to appear in the practical exams, and these sessions helps you gain that confidence and skill. Okay, so we have 4 kind of subscription plans here at Auricle. We have foundation plan for 3 months with 3 months validity. We have advanced learning plan with 6 months validity, complete learning plan with whole 1 year, that is 12 months validity, like for the complete third year or the final year, or whichever plan you're opting for. And we have the ultimate MBBS plans. If you want Auricle lectures from the right from the first year, from the basics to your clinical subjects like medicine, surgery, or that is final year. So you can opt for this ultimate MBBS plan. So it gives you access to almost everything that we provide here at Auricle. So you can opt for the ultimate MBBS plan as well. So these are subscription plans. And let's start our today's topic, that is practical aspects of the ophthalmology, part 1. And there is another part 2 of this module, that is practical part of the ophthalmology. Okay, so today we'll be discussing only the half of the part. So the first thing that we're going to discuss is the sudden painful loss of vision in a 34-year-old female. So what are the causes for this sudden painful loss of vision? So remember, we are discussing painful causes of the loss of vision and not the loss of vision causes. Okay, we are not discussing the causes for the loss of vision or the sudden loss of vision. We are discussing sudden painful. The painful word is very important over here. Okay, so we are discussing the sudden painful loss of vision in a 34-year-old female, or you can say mid-aged female. Okay, mid-aged female, because this is not young female or this is not older female. So this is a mid-aged female. So we are going to discuss about the causes for the sudden painful loss of vision in a mid-aged female. So this includes acute angle closure glaucoma. So if this acute angle closure glaucoma, or you're developing an increased IOP, acute increased IOP or intraocular pressure, then you can have sudden painful loss of vision. The second cause is optic neuritis. Third cause is central retinal artery occlusion. Fourth cause is endophthalmitis, trauma or hyphema. Sixth cause is uveitis. Seventh cause keratitis of the corneal ulcer. Okay, so these are the 7 most important causes for the sudden painful loss of vision in a mid-aged female. So this is a very important question, and we are discussing particularly this mid-aged female because it is because this question has come in a previous year questions or your previous 10-year PYQs. So this is very important, and that's why we're discussing it as a separate heading. Okay, so this has come very frequently in your previous year questions. So just remember these 7 causes, and we are going to discuss about the causes in detail, okay, in the upcoming slides. So there can be glaucoma, there can be optic neuritis, there can be central retinal artery occlusion, endophthalmitis, trauma or hyphema, uveitis, that is inflammation of the uveal tract, and there can be keratitis or corneal inflammation. Okay, so these are the 7 causes for the sudden painful loss of vision in a mid-aged female. So every word is important. Sudden means acute, painful, that is with pain. Okay, loss of vision in a 34-year-old, that means mid-aged female. So every word of this is very important. Okay, just don't confuse this as the causes for the sudden loss of vision or causes for loss of vision. Okay, it is a sudden painful loss of vision causes, right? Okay. Not a differential diagnosis of a sudden painful loss of vision, or you can this can also be interpreted as like causes of sudden painful loss of vision. So first of all, as we discussed, we have acute angle closure glaucoma. So we'll discuss about the acute angle closure glaucoma. So if you're having an acute angle closure glaucoma, what are the signs and symptoms? So you can have severe eye pain, you can have headache because of increased IOP. Okay, you can have nausea, vomiting. Okay, you can have mid-dilated non-reactive pupils, as already discussed in the glaucoma part. Okay, I've already discussed the mid-dilated non-reactive pupils. That is one of the symptom or sign in the acute angle closure glaucoma. You can also have the cloudy cornea, also known as hazy cornea. Hazy cornea. So you can have hazy cornea. You can have severe eye pain, headache, nausea, vomiting, mid-dilated non-reactive pupils. So these are the 4 to 5 important signs and symptoms associated with the acute angle closure glaucoma. How do you manage this condition as the IOP is increased? So as the IOP is increased very acutely, so our main aim is to reduce the IOP as soon as possible. So our main target in the management part is to immediately reduce the IOP with IV acetazolamide. Okay, IV acetazolamide or hyperosmotic agents like mannitol. Okay, like mannitol. Laser peripheral iridotomy can also be done in responsive patients to acetazolamide or hyperosmotic agents. If the patient is not responding to acetazolamide or hyperosmotic agents, then you can go for laser peripheral iridotomy as soon as possible, because this is a surgery, right? Laser peripheral iridotomy, you are just giving the laser, but it is more or less like a surgery only. Okay, it is a very small surgery, but it's still a surgery. So this immediate IOP reduction is a primary aim to reduce the IOP as soon as possible. Otherwise, it may lead to the permanent vision loss. Okay. Optic neuritis. So the optic neuritis, that means inflammation of the optic disc, inflammation of the optic nerve. So there can be pain on the eye movement. There can be central vision loss. There can be afferent pupillary defect. Okay, afferent pupillary defect, it is also known as Marcus gun pupil. Marcus gun pupil. So you can be having pain on eye movement. You will be having central vision loss, and you will be having Marcus gun pupil. Okay, how do you manage this condition? Since it is an inflammation, you will give corticosteroids like IV methylprednisolone or neuroimaging to rule out the multiple sclerosis, because multiple sclerosis is often associated with the optic neuritis. Okay, it is one of the most important risk factor or cause for the optic neuritis. So you have to rule out the multiple sclerosis. If the multiple sclerosis is present in a patient with optic neuritis, then you know that the cause for this optic neuritis is multiple sclerosis only. And you have to treat the multiple sclerosis, and the optic neuritis itself will resolve on its own. Okay. Other than that, you can give IV methylprednisolone. So this is about the optic neuritis. Now, central retinal artery occlusion. Okay, the term itself tells that there is an occlusion of the central retinal artery. So sudden profound vision loss or cherry red spread on the macula and pale retina. So this is the three fundus picture of the signs that you see on the fundus. Okay, or it can be also perceived as the symptoms of the central retinal artery occlusion. Now, how do you manage this condition? You manage this condition by ocular massage, acetazolamide, anterior chamber paracentesis, okay, or immediate referral. Immediate referral. Immediate referral is also one of the management, because if your hospital or if your center is not having the facility to treat such problems, then you should immediately refer the patient to a higher facility. Okay. Other than that, you can give ocular massage or acetazolamide or anterior chamber paracentesis. This is the mode of management for the central retinal artery occlusion. Other than that, the fourth important cause for sudden painful loss of vision is endophthalmitis. Okay, it is endophthalmitis. So endophthalmitis means, I told you, endophthalmitis means inflammation affecting all the three layers of your eyeball, that is sclera, choroid, and the retina. All the three layers is inflamed, so there can be severe pain, redness, photophobia, hypopyon, and decreased vision on the affected eye. Okay, so there can be severe pain, redness, photophobia, hypopyon, and decreased vision. Hypopyon means pus in the anterior chamber. Hypopyon is pus in the anterior chamber. Okay, now how do you manage this condition? By intravitreal antibiotics or vitrectomy in severe cases. Okay, either you can give intravitreal antibiotics or vitrectomy in severe cases. Now, what is the cause of gradual loss of vision? So we have discussed a sudden loss of vision. Now we will discuss about the gradual loss of vision. So if you have refractive errors like myopia, hypermetropia, astigmatism, presbyopia, so these are the refractive errors. These are the common refractive errors. So if you are having high-grade myopia, high-grade hypermetropia, high-grade astigmatism, so all these things will gradually lead to the loss of vision. Okay. Other than that, we have cataract and glaucoma as the leading cause of gradual loss of vision. You can have age-related macular degeneration, ARMD, age-related macular degeneration, diabetic retinopathy, and retinitis pigmentosa. These are the retinal disorders. Okay, retinal disorders. This is the lens disorder. Right. So this was about the gradual loss of vision. Refractive errors like myopia, hypermetropia, presbyopia, astigmatism. These are the refractive errors, common refractive errors that can lead to the gradual loss of vision. Cataract glaucoma is also a leading cause, as you all know. Other than that, we have ARMD or age-related macular degeneration, diabetic retinopathy, retinitis pigmentosa. This all lead to the gradual loss of vision, right? Now, we will discuss only one of the cause for the gradual loss of vision in detail, that is cataract. So we have already discussed cataract, but we'll discuss in short about the cataract, not the whole discussion of the cataract. So as you know the definition of the cataract, it is a opacification of the crystalline lens leading to the progressive vision loss. Progressive means gradual, right? So it is an opacification of the crystalline lens, opacification of the crystalline lens leading to the progressive vision loss. So this is a definition, not types. Types include senile cataract, congenital cataract, traumatic cataract, and secondary cataract. So these are the four types that we have already discussed: senile, congenital, traumatic, and secondary cataract. These are the types. Remember the clinical features: gradual, painless loss of vision, glares, monocular diplopia, and reduced color perception. Okay, reduced color perception. So these are the these are the five clinical features that you can observe in the patient of the cataract. Okay, so not going into detail about the cataract because we've already discussed in our previous live sessions. So we'll just keep it short and we'll only discuss about the management part of the cataract in the next slide. Okay, so how do you manage the cataract? So these also we have discussed. The most commonly done nowadays is the phacoemulsification process. Okay, this is the phacoemulsification process most commonly done nowadays. But the recent advancement shows the femto laser assisted cataract surgery, which has more advantages and it is more easier, okay, to do this FLAC surgery and with less complications. Okay, FLAC surgery, that is femto laser assisted cataract surgery. But since this is very costly and available only in a limited facility, okay, not available in every hospitals or facilities, so it is limited, but it will become more and more famous in the upcoming years. So the non-surgical options for the cataract management includes early stages with glasses or magnification. Okay, either you prescribe glasses or magnification, the early cataract or the surgical, but this is not very common in the cataract patient because the cataract patient, whenever they present to the clinics, they already have the terminal stage for the cataract. So surgery is the main option, or surgery is the main treatment for those patients. So phacoemulsification is the first preferred and the most commonly used process nowadays. And the second is manual small incision cataract surgery, also known as MSICS. Okay. And third is the intraocular lens implantation. Okay, so intraocular lens implantation is associated with both of these surgery. So in phacoemulsification, also you implant IOL. In MSIES, also you implant an IOL. So these are the surgical options. Okay, so these are surgical options for cataract, and you should know the recent advancement and the full form of the FLAC surgery because it is very important that at least you should know the name of this surgery. Okay, femto laser assisted cataract surgery, FLACS, or manual small incision cataract surgery, which is MSICS. Now we'll discuss about the tonometers. Okay, so tonometers, what are the tonometer or not is tonometry? So tonometry, I told you, it is a measurement of IOP. Measurement of IOP or intraocular pressure. Okay, intraocular pressure is measured by tonometers. Okay, so first we'll discuss about the contact tonometers. Contact tonometers. So we have different types of tonometers: contact tonometers, non-contact tonometers, and dynamic tonometers, right? So in contact tonometers, we have Goldman aplanation tonometer. Goldman aplanation tonometer. Okay, so we are discussing about the tonometers, right? And as such, in the UG level, it is not something that you see in your daily practice. Okay, tonometers, you should just remember the classification of this and the use of the tonometers. So just remember the names of the tonometers because it is very important, and you should remember the classification at least. Okay, so that much is sufficient for you if you remember the classification and the names of the tonometers. Okay, so first is we are discussing about the contact tonometers. And contact, the first is the Goldman aplanation tonometer. Goldman aplanation tonometer. Second is Perkins tonometer. Third is Schiortz tonometer. So we have Goldman, Perkins, and Schiortz tonometer. Let me tell you, the Schiortz is the most common used. Okay. In my hospital, it is the most commonly used tonometer, right? So Schiortz tonometer is the most commonly used. So in the right hand side, you can see this is a Schiortz tonometer. Okay, so this is the foot plate. This is the foot plate. and this is used to measure the IOP. Okay, the part that touches the eye. So this is the part that touches the eye, right? The foot plate. So the non-contact tonometers include the air puff tonometer, and the dynamic tonometer is the Pascal dynamic contour tonometer. So these tonometers are not frequently used. So non-contact tonometers is in the advancement and is being researched. So because it is a non-contact, okay, the tonometers does not come in contact with your eye. So that is air puff tonometer. Okay, and dynamic tonometers works in some dynamic principle. You don't need to know about this. And contact tonometer, this Goldman efficient tonometer, Perkins tonometer, and Short's tonometer. These three tonometers come in contact with the eyes. Okay, it requires the contact with your eyes. Therefore, it is known as contact tonometers. Now, Goldman application tonometer, the advantages and disadvantages. Okay, so advantages, it is accurate and gold standard. It is a gold standard tonometer. Very, very important. Goldman application tonometer, it is a gold standard. You can remember it in the name itself. It is Goldman. Okay, so gold standard. Okay, so gold standard is a Goldman application tonometer. Disadvantage, it is that it requires slit length and it is affected by the corneal thickness. Okay, it requires slit length and it is affected by the corneal thickness. Non-contact tonometer, we have, it is quick and no anesthesia is required in the non-contact tonometer. And disadvantages is that it is less accurate. It is less accurate. So no anesthesia is required in a non-contact tonometer because you are not touching your tonometer with your eyes. Okay, so no anesthesia is required and is less accurate. So, but it is in the recent advancement that more and more non-contact tonometer is being preferred because the patient does not want the tonometer to touch their eyes. Okay, because it is very, sometimes it is very painful for them also because it is the anesthesia. It means soft. Okay, it's some period of, after some period of time. So some patients they are not okay with the non-contact, contact tonometer. They prefer non-contact tonometer. Okay, so that is about the tonometers, contact, non-contact, and the dynamic tonometers, right? In contact tonometers, we have Goldman applanation, Perkins, Short's. In non-contact, we have air puff tonometer, and in dynamic, we have Pascal dynamic contour tonometers. So that is about the tonometers. Now, what is B-scan and its uses in ophthalmology? So B-scan is the brightness. The full form of B is brightness. The full form of B is brightness. So B-scan and its uses in ophthalmology. So it is the ultrasound technique to assess the posterior segment structures. So it is used to assess only the posterior segment. So B-scan, it is used, it is an ultrasonography or USG, okay, to assess the posterior segment structures. Now, what are the indications or why do we need to get this scan done? Okay, so if you're having an opaque media, example, cataract or corneal opacity, if you're having a cataract or if you're having a corneal opacity, then you cannot examine the patient eyes. Okay, you cannot examine the patient's fundus. We have discussed this earlier also, because if there's any issue over here, okay, so this is the cornea and this is my complete eyeball and this is the lens, right? So if there is problem over here or if there's problem over here, then I cannot visualize this part, right? I cannot visualize this part because I can be visualizing, this part is visualized only through this layer, only through this way, right? Only through this way. And if this thing is deceased, then we cannot see this thing, right? We cannot see this layer. Okay, so that's why the cornea and the lens has to be proper or has to be normal, okay, to visualize the fundus or to visualize the posterior segment structures. Okay, so if there's opacity or if there's opaque media in the cornea or in the lens, that is cataract, then you cannot visualize the posterior segment, and therefore you need the B scan or the ultrasonography to visualize these structures, right? Or you can have, or if you have retinal detachment, tumors, or foreign body localization, then also this B scan is preferred mode of investigation. And advantages is that it is non-invasive, quick, and widely available. Okay, so it is non-invasive. Obviously, it is non-invasive because it is ultrasonography. It is very quick and is widely available. So you can see on the right-hand side that we have ultrasonography. This just looks like sonography of a uterus that we do in a pregnant female. Okay, it is same like that. So this is the hyperechoic part, and this is the hyperechoic part, and this is the hypoechoic. The white one is known as hypoechoic. So in the sonography, you have hypoechoic and the hyperechoic part. This is hypoechoic, and this is hyperechoic part, right? Hypoechoic and hyperechoic part. So this is the part. So this is the retinal detachment. So this is the retina layer. This is the retina layer. Okay. So the retina is detached from the these layers. Okay. So this is the complete layer of the eyeball, and you can see retina is detached because there is a gap in between. Okay. Retina is detached from the other two layers of the eyeball. And this is vitreoretinal traction because this is the traction. See, this is the pulling away the retina. This is pulling the retina away from the other layers. So this is vitreoretinal traction, and this is a retinal detachment. So you can visualize the retinal detachment tumors. Okay, if there's tumors, it will appear as a tumor. Or if there's a foreign body in the posterior segment of the eye, then you can localize the foreign body and where is it present. And this is also used if there is an opacity in the cornea or the lens, then you can easily visualize all the structures in the posterior segment. Okay, so these are the advantages, indications, and what is hyperechoic, hypoechoic, and what is B scan. Okay, so it is a widely used mode of you can say diagnosis for the ophthalmological disorders. Okay, the next thing we're going to discuss is the colored halos. Okay, so the colored halos, you can see this is the colored halo on the right hand side. So what are the causes for the colored halos? So acute annular glaucoma, corneal edema, cataract, and dry eye syndrome. So these are the four most important causes for the colored halos. So colored halos is it is not a very separate question. Okay, it will come as a enumerate the cause for colored halos and what are colored halos. So you can write the causes of the colored halos. So just remember these four causes because these are the most important causes for the colored halos, and you should remember these four important causes. So in the cataract, if you're having immature stage of the cataract, then you can have this colored halos. Dry eye syndrome is one of the most important cause for the colored halos, or corneal edema or keratitis can also be a cause of colored halos, and the acute annular glaucoma. Okay, so these are the important causes for the colored halos. Now, you must have at least seen this chart once in a lifetime whenever you have visited an ophthalmologist. Okay, so this is a Snellen's chart. Okay, this is known as Snellen's chart. This is the Snellen's chart. Okay, this is the Snellen's chart. So what is the Snellen's chart? What is its use? So the purpose of this Snellen's chart, you must already know that it measures a visual acuity. Okay, it gives you the power of your eye. That is known as a visual acuity. So it measures our visual acuity of the eyes. So it consists of the rows of letter decreasing in size. Okay, so the size is decreasing. The size of the letters is decreasing. Okay, so this is the decreasing size. What are its uses? It is used in assessing the refractive errors if you're having any myopia or hypermetropia, for pre and post treatment visual evaluation. Okay, so for example, if you already had myopia, you got treated by LASIK surgery for that myopia, and you want to again get your visual acuity checked, then you can get it checked by this Snellen's chart, right? And it is also used for vision screening. Okay, it is because in most of the institutes, it requires your medical checkup, right? In medical checkup means the medical checkup includes the vision screening. Okay, so in the vision screening part, the Snellen's chart plays an important role, or rather, it is the only thing that checks your vision. Okay, because it checks your visual acuity. Okay, so this is about the Snellen's chart. It is one of the most important tool to assess the activity of your eyes or the activity of your vision. Okay, so it is the most important thing because visual acuity is everything. If you cannot see, that means your eye is completely damaged. So visual acuity is the first thing that you get checked whenever you're having any eye disease. Okay, so Snellen's chart is widely used. Now, the last topic of our today's discussion is the methods of recording IOP, or how do you measure your intraocular pressure. So intraocular pressure measurement, we already discussed in one slide, that is tonometry. Tonometry, right? Tonometry. So tonometers are used. Okay, so we have aplanation methods. So aplanation methods includes Goldman and Perkins tonometer. We have indentation methods, which includes Short's tonometer, non-contact methods, which includes air puff tonometer, And dynamic contour tonometry measures true IOP independent of the corneal properties. So it measures the true IOP and it is not dependent on the corneal properties. Whatever the cornea, if there is any hazy cornea or if there is any inflammation of the cornea, it does not depend on the corneal properties. Other methods depend on the corneal properties. Okay, these depends on the corneal properties. And dynamic contour tonometry does not depend on the corneal properties. So dynamic contour tonometry measures true IOP, and other methods, these also measures the true IOP, but it does not, but it depends on the cornea. If you have a healthy cornea, then it's giving the fine reading. Okay, if you're having any hazy cornea or if you're having any infection in the cornea, then these three methods, that is appendation, indentation, non-contact method, they will give a faulty reading or the some errors in the measurement. Okay, so this is about the measurement of IOP. So this was about the first part of the practical aspects that we have discussed. So we have discussed about the causes for the sudden loss of vision. We have discussed about each of the causes in detail. We have discussed about the gradual loss of vision as well. We have discussed about the cataract management, phacoemulsification, which is very important. We have discussed about tonometers, methods of recording intraocular pressure, tonometry. Just remember, the methods of recording is one separate thing, and tonometers classification is one separate thing. Just don't mix the two things, right? Because both can come as a separate question. Methods of recording intraocular pressure. Okay. So there are four methods: apprention method, indentation method, non-contact method, and dynamic contour tonometry method. So these are the four methods. And the classification, we have contact method, non-contact method, and the dynamic methods. Okay, those are the three methods for, sorry, those are the three classification for tonometers, right? And we have discussed about these things. Okay, so this was about the practical aspects, the first part of the practical ophthalmology. Tomorrow we are going to discuss about the practical ophthalmology part 2, and we will discuss the remaining topics of this practical aspects. Okay, so what are the summary of the key points? So the sudden painful or loss of vision requires urgent diagnosis and treatment, like you want to urgently decrease the IOP in case of acute angle closure glaucoma. So you give IV acetazolamide. Okay, so that is the urgent intervention. The gradual loss of vision. The gradual vision loss commonly involves cataract, refractive errors, and glaucoma, as already discussed. Tonometry and V-scan are essential diagnostic tools. These are the very essential diagnostic tools and most commonly used diagnostic tools, okay, in ophthalmology. So tonometry and V-scan, we should not forget. Colored halos, Snellen's chart, and IOP reading techniques are critical in clinical practice, right? And Snellen's chart is the most widely used clinical techniques in the ophthalmology OPDs or ophthalmology wards or in any eye clinic, right? Snellen's chart is the most widely used. So this was about the summary of today's session. So thank you very much for your patience listening, and we'll meet again tomorrow with the next few set of important concepts and the topics for regarding the practical ophthalmology. Thank you very much. Hello. Hello.
Yes, sir. Yes, sir.
Okay. Thank you. Thank you very much.
Thank you, sir.